Hello, everyone. My name is Gadia, and on behalf of the organizing committee, I would like to welcome you and thank you for taking the time to attend the annual International Active Sickle Cell Disease Group meeting, which is organized by TIF. Before giving the floor to our speakers, I would like to extend our special thanks to the medical experts who have and will be contributing to this meeting. And I'm also delighted to announce that Professor John Porter is with us today. Professor Porter is the head of the Joint Red Cell Unit for University College London Hospitals and Whittington Hospitals. And we are very grateful that his international expertise and knowledge are at the panel's disposal today. I would also like to extend our thanks to Sickle Cell Disease Coalition, who will be contributing to this meeting. And finally, I would like to extend our thanks to the sponsors, Nova Laboratories, PharmaPal, and HemaNext. Before we begin, I would like to just point out some things regarding this meeting. Today's session is being recorded, and the video recording will be uploaded on TIF's website. You probably have noticed we have enabled the live transcript. If you want to remove it, you can do so by choosing the live transcript icon at the bottom of your screen and hide the subtitles. If you have any questions for the presenters, please use the chat feature. You can post your question there and you can address it to a particular speaker. If you have any technical issues or any technical questions, please reach out to us through the chat or through the email address that I will be posting in a few seconds in the chat. Lastly, lastly and very important, as you have control of your microphones, please make sure that you are on mute while the presentations are in progress. During the interactive session towards the end of the meeting, please use the raise your hand option to speak. So without any further delays, I would like to introduce our first speaker, TIF's medical advisor, Dr. Michael Angustinotis, who in the next 10 minutes will be explained to us why TIF and sickle cell disease. So Dr. Michael.
Okay, so thank you very much, Gadia, and apologies for the change in the order of the speakers.
Okay.
I'm just ready to welcome everybody on behalf of Thalassemia International Federation. It is always my privilege to represent the global thalassemia family through the work of Thalassemia International Federation. Just very few basic slides on how TIF works. In a minute. So we are all, and let me also on behalf of TIF thank the international experts and all medical experts that are here with us in this international active sickle cell disease group created by, developed or established, if you like, by Thalassemia in its interest of supporting in as many ways as possible our sickle cell disease patients. And Dr. Michael Angustinotis in a minute will describe why Thalassemia International Federation has been or has started getting involved in the educational program of sickle cell disease patients, being by constitution an organization focused on thalassemia. So it is my privilege to describe the work of Thalassemia International Federation in just a slide. We work since we were established in 1986 by a small group of patients, and we are today embracing and trying to safeguard the rights of patients in nearly 300 patient support groups all over the world across the 6 regions as these are defined by World Health Organization. But very importantly, we work with official stakeholders since 1996 with World Health Organization, which has been very supportive in our work across the world. We have a consultative status since 2017, 18 and 19, of course, with the United Nations Sickle Cell in partnership with the European Commission and member of the Council of Europe Conference. In addition to that, we are collaborating with a number of medical professional bodies, and these support our work towards safeguarding the rights of our patients. Now, our work is based on 5 pillars of activities, amongst which are policy advocacy, education, networking, undertaking of projects, and research projects are most of our activities. Our activities and actions are involving or are directed both towards the patient community, but also towards the healthcare community. Some of our very useful and meaningful collaborations, apart from European Commission and the United Nations and World Health Organization, include the European Hematology Association, the European Association for the Study of the Liver, the International Society of Blood Transfusion. And we do participate in an active way and with an active role in the advocacy groups of these bodies. We have close relation, of course, with industry and on a project-based way, in a project-based way. Most of our associations across the world are associations that embrace the rights of patients, both with thalassemia and sickle cell disease and patients. And that's the reason why we decided that in our policy work, and very importantly in our educational program, we'll be including sickle cell disease to help within our infrastructure and within our constitutional alliance, our patients and peers with sickle cell disease. We collaborate with every sickle cell disease, other stakeholders, whether medical societies or whether patient-orientated, so that we can complement their work and share best practices and work with each other on specific disease-specific projects. That's all for me, and I welcome each and every one, and truly thank you for your presence in this webinar. Michael? Oh, sorry.
Okay, hello from me also, everyone. Nice to be able to communicate with you, even from a distance. We are frequently asked the question, since we're a thalassemia organization, why are we involved with sickle cell disease? And I'm going to be very brief in my answer, because I know that most of you actually know the answer already. Why is it involved? The answer, the answer lies first in the epidemiology. In at least 50 countries that we're concerned with, and TIF is working with about 60 countries. In about 50 of these countries, both conditions coexist. In the map that you can see over there, we have colored in dark. The darker the color, the more number of patients of both conditions per population. This is one of the many possible indicators of the burden of disease, but I just took it as an example. So across many countries, we coexist. And not only do we coexist geographically, but the patients of both conditions are treated usually in the same clinics, usually by the same physicians, and have to help in the development, if you like, of the same services. If the services are to develop, they've got to develop for both syndromes. TIF cannot serve, for example, the thalassemia community alone without serving the sickle cell community that's living in the same clinic. So, and not only that, but the support associations in most of these countries are actually common. Not all of them, but in most countries. So we have common needs, and common needs lead to common challenges and common actions. Advocacy is one of the roles that, as Andrula has described, is required so that we can achieve optimum care. We can promote patients' rights. These have to be for both kinds of patients. Education of healthcare professionals, education of patients, all these educational issues that will raise the standard eventually of patient care. These are also common to both. Support associations usually include both kinds of patients. And in fact, I could give you examples. For example, the Federation of Turkey has been led until recently by sickle cell patients, even though the thalassemia patients are a majority. In some other areas, we have the reverse. The issue is that the patient support associations are very often together. Common treatments are used. In both conditions, we use medications, we use blood transfusions. So the issues are common. New therapies are actually coming along, and some of them are actually shared by both syndromes. So collaboration of the sickle cell national and international groups with TIF, and by taking common actions, complementing each other, it makes sense and is a necessity. So I end up with a motto that TIF has used years ago: unity is our strength. And this is the reason why TIF is promoting sickle cell disease. Thank you.
Sorry. Thank you, Dr. Angustinotis. Now we have the pleasure of having with us Dr. Lucia De Franceschi, who is an assistant professor of internal medicine at the University of Verona, Italy. And she will be giving us an overview on the care and cure of adult sickle cell disease patients.
Thank you for the invitation, and I'm really honored to contribute to this discussion, and I'm really happy of the high attention of TIF on sickle cell disease. So I try to share my screen in order to start my presentation. Can you see the title?
Yes.
Okay, so the title is really is very big, it's very large, the area you asked me to cover. So I tried to come out with some info and on the other side also perspective. When I start talking about what is care of sickle cell in Europe, which means the European community and UK, and we are dealing with something that is around 35 to 40,000 of patients, but the general sense is that a large part of patients are not under database on any register, so probably there is a large part of patients that are not referenced for a follow-up to comprehensive sickle cell center throughout Europe. So when we look to the financial healthcare in Europe and the UK, this is basically public with some form of taxation, and this is definitely different from what is in other countries all over the world, and in comparison, for example, with the United States. This is definitely that in the European community and the UK may be considered compared to other countries, even countries such as the United States, very high standard. So generally, sickle cell patients are referred to either sickle cell comprehensive centers or such as in Italy, but I think in Greece too, in centers for hemoglobinopathies, where a patient with both beta thalassemia and sickle cell disease are generally referred to. In Europe, we have also the European Network for Rare Anemias, and although both thalassemia and sickle cell are not, it's difficult to define as rare disorders, both diseases are part of this, of the area of interest of EuroBloodNet. When we look to the distribution of sickle cell in Europe and UK, this is absolutely changed throughout the last 10 to 20 years, mainly related to voluntary migration from area where sickle cell was endemic, making sickle cell disease as a disorder and common in area where it was not originally endemic, such as in Italy or in Greece. And you can see in this slide the trends in the risk of the population, for example, in England, in Wales, or in France, in Belgium, or in the Netherlands. And this is very important because a similar data projection on the Danish population, considering more than 10 years, 15 years of observation, show a fivefold increase in the Danish population of sickle cell patients, but also of patients with sickle cell trait. And you clearly see in both graphs reported on the right part of the slides. So management of sickle cell patient means identification of the subjects with sickle cell disease, accessibilities to screening program for sickle cell clinical complication, and of course, pediatric care, adult care, and whenever it's possible to have a transition from pediatric care to adult care, which should be assisted in order to allow the patient, pediatric patient, or adolescents to move to the adult care without any major problems. Concerning the identification of the patient, different strategy should be considered. One is the neonatal screening, one is the antenatal screening, and since Europe is also an area for incoming population with potentially with sickle cell disease from area where this disease is endemic, the screening of refugees. So when we look to the different screening, neonatal screening is not established in all the European countries, and even within the European countries, in some countries it is universally, in some others, such as France, is on target population. Antenatal screening is instead available, should be available all over the different European countries, and the screening of refugees has not been established, and we have only experiences in areas of Europe, such as Italy. Concerning the European sickle cell population, of course, we have, as I mentioned before, to consider endogenous sickle cell population, so Italy, Greece, Albania, Portugal, and then we have the exogenous, so the voluntary migration from endemic area for sickle cell disease. So the healthcare for patients with sickle cell disease should consider at least 3 different area of action. One is the general practitioner. The second one is first contact center, and then the expertise centers. This means not only the possibility to correctly define acute sickle cell complication, but also to offer a complete follow-up for possible chronic sickle cell related complication. And on the other side, as is summarizing these slides, this means also that expert center should be taking care of also of the implementation of the network within the first contact centers and general practitioner, but also education of these 2 different first contact center and general practitioner in order to ensure the correct management also in general outside the expert centers of these patients. So the available treatment right now in Europe are bone marrow transplantation, hydroxyurea, and transfusion strategies to limit acute and chronic sickle cell related complication. And concerning the hematopoietic stem cells, and this is a summary of the data from the European Bone Marrow Transplantation Registry, which is considering both thalassemia transfusion-dependent patient, but also sickle cell patient. You see almost 920 bone marrow transplanted patient has been treated over these years with a median age of 7.23 years and the median follow-up of more than 15 years. And as you see in this slide, the large part of the patients were transplanted in an age lower than 14 years, whereas a smaller amount of these patients were transplanted between 14 and 17 years of age. Here you have on the right the strategy that has been used, and as you can see, the majority of the patients were HLA identical sibling strategies at bone marrow transplantation. Here you have the survival free from the disease, which is absolutely fantastic. And on the right, you have the summary of 2 main points that come out from this study, showing that the profile of the patient that should be considered for bone marrow transplantation is a subject that is younger than 14 years of age for both diseases. And of course, the strategy is an HLA identical as the best option for both disorders. Concerning hydroxyurea, the possibility to start the treatment should be offered as soon as we are available, the diagnosis available. But as you see here in this slide, the strategy is absolutely not homogeneous all over the world. For example, in the United States and the UK, the starting age is after 9 months, regardless of the clinical severity. Otherwise, in the last part of the European country, there is no consensus. And the common indication are recurrent vaso-occlusive crisis, or acute chest syndromes, or transfusion problems related to alloimmunization, or positivity to the Doppler transcranial Doppler screening, or otherwise, as you can see here in summary, severe anemia or renal impairment. And this is very important to point it out because the absence of homogeneous behavior, homogeneous way to choose the starting of the hydroxyurea treatment may generate differences in the quality of care, especially in areas where blood transfusion may not so easily available. So starting the work with the NERCA, and then we generate a recommendation that are actually need to be updated under the umbrella or either EA or AeroBloodNet. And you see here a table which summarizes the indication for the different transfusion regimen, considering acute simple transfusion related to where the indication is acute sickle cell related complication, chronic simple transfusion or exchange, or acute exchange. As you can see, I would like just to underscore that there are controversial, even in this area, indications such as recurrent vaso-occlusive crisis non-responsive to hydroxyurea, recurrent priapism of chronic leg ulcers. Of course, when we talk of acute sickle cell related manifestation, the main cause of oxidation are pain crises. And concerning the severity, these require, of course, a very, rapid identification of the pain crisis, the definition of the pain crisis, and identification, and of course, a time-dependent starting for analgesic treatment and the use of pain-killing drugs. Here, I just would like to show and to share with you two different approaches. On the left, you have the UK, and on the right, you have an algorithm we developed in Italy to offer the best management for patients with pain crisis arriving in the emergency department. And as you know, the patient with sickle cell disease are the higher utilizer of emergency department, even compared with the other patients with severe hemoglobinopathies, such as beta thalassemia patient. And it's very important to contribute to the education and to the development of local and national guidelines for management of acute events in patients with sickle cell disease in order to optimize the treatment, but also to ensure the a rapid treatment of pain. So when we think to pain, we have also to think that in sickle cell disease, pain has different origin. At least we may recognize neuropathic pain, inflammatory neurological pain, and of course, idiopathic pain. And this is associated with the rearrangement of pain perception, both peripheral but also central. And due to these central changes in alteration of the perception of the pain, this is requiring a multimodal approach to obtain the best results for patient in order to reduce the anxiety of patient when they are experiences pain. And for example, one approach may be the use of multimodal therapy, which use different molecules with different mechanism of action in order to target the mechanism of pain, the different mechanism of pain which are involved in sickle cell disease. So when we talk, for example, to balance analgesia or multimodal analgesia in this patient, one example is summarized in these slides, maybe the combination of tramadol, which is a opioid-like molecule, or morphine with ketorolac in adult patient, or in paracetamol in children. And of course, we may use, or we may consider to use pain-breaking drugs such as fentanyl, with which, for example, oral or nasal, with oral nasal strategy in order to obtain as soon as possible the control of pain and try to impact the experience of the patient. So recently, within the new portfolio of treatment for sickle cell disease, we have crizanlizumab that has been defined as an orphan drugs by with the name of Adakveo in September of last year, and by now is under discussion in the national agency. And concerning the others, for L-glutamine, the application was withdrawn by the company, and the cause was changes in market strategy. Concerning Voxelator, right now EMA is in discussing about the possibility to have also this compound in Europe available. So when we consider the definition of vaso-occlusive crisis in patients with sickle cell disease, in order to optimize the treatment, we have to consider to define the duration, the pain intensity, whether this treatment requires or not medical approach, and whether this pain crisis required doctor evaluation. And this is very important because to identify, let's say, not a common way to define, not only a common way to define pain crisis, but also, and this will be very important in perspective to define the efficacy of the different treatment and also to design the study. I have to move to another PowerPoint because my line, the connection is not very stable, okay? 30 seconds.
Okay.
Unfortunately, sometimes lines are not really helping us. Okay. Can you see the screen right now?
Yes, yes.
Okay. So when we look to the pathophysiology of sickle cell disease and we discuss about the different therapeutic strategy, which are summarized in these slides, as you see, hydroxyurea is targeted at least 3 different, key moments, a key pathway in sickle cell clinical manifestation, chronic hemolysis, and acute vaso-occlusive crisis. And of course, if we want to add the 3 different, molecules that we just discussed on, so Voxelator, crizanlizumab, and L-glutamine, you see where these are placing. So one is targeting oxidative stress, but we are not discussing this. One is targeting inflammatory storm and inflammatory vasculopathy, crizanlizumab, we will discuss. And we will discuss also Voxelator, which is an anticycline agent. So let's see the next molecule, which is Voxelator. And Voxelator is a very interesting molecule. It's an oral available potent anticycline agent, which is bridging into globin chain and is blocking depolymerization or delaying the polymerization of hemoglobin S. And this is very important because as soon as the polymerization of the hemoglobin is not into the microcirculation, but after the microcirculation, the possibility of dense and dehydrated red cells to be trapped should be reduced. And indeed, the results from the studies with Voxelator, so the OP studies show that Voxelator at the dosage of 900 and 1,500 milligrams per day with over 20 weeks of treatment is able to impact hemoglobin levels and also seems to reduce VOC events. What is interesting, and you see here in the graph on the right, the cumulative VOC incidence is definitely not affected by hemoglobin concentration. And this is very important, especially when you consider combined treatment Voxelator with hydroxyurea, which is summarized in this slide, and you see there is no major impact on hemoglobin levels or in different parameters, and this is very important in perspective. So there was one abstract at the ASH meeting last year pointed out that patients with sickle cell disease at the higher dosage of Voxelator, so 1,500 milligrams per day, show an improvement in the clinical global impression scale changes, suggesting an improvement of quality quality of life of patients with sickle cell disease undergoing to Voxelator treatment. So when we look to crizanlizumab, which is the second molecule we are discussing together today, data are being generated by two main studies, the SUSTAIN study and the SOLANGE study. These are double-blind placebo-controlled multinational studies, and you see on the right one of the key figures showing that the crizanlizumab at the dosage of 5 milligrams per kilo every 3 weeks is able to reduce the vaso-occlusive crisis and also to increase the time length between pain crisis. Something that is very interesting is that it's safe, well tolerated, and is able to induce a persistent P-selectin blocker for over than 1 month. The SUSTAIN study were involving and enrolling a patient with all the different genotypes that are related with sickle cell disease, so SS, SC, and beta 0 and beta plus. There have been study patient at 2 different dosages coming out that the dosage at 5 milligrams per kilo every 3 to 4 weeks is the dosage that were more successful considering the primary endpoint of the study. And something that was very interesting was that part of the population was naive for hydroxyurea, the other was already on treatment with hydroxyurea, and crizanlizumab at the dosage of 5 milligrams per kilo every 4 weeks was effective also in patients with hydroxyurea in reducing the rate of pain crisis. So when we take a look to a peplin study related to the SUSTAIN, and this data have been presented last year at the ASH meeting, considering the use of opioids before and after or during the study, what it came out is that crizanlizumab in sickle cell treated patient was able to reduce almost 50% in the days per year in which these patients were using parenteral opioid to limit or control sickle cell related pain. So I think that even this information is very interesting in perspective. Of course, we have no data concerning whether crizanlizumab might affect natural history of this sickle cell disease, but due to the chronicity of this disorder, we need a time of observation of 10 years, at least 10 years, which is definitely out of the time of any clinical studies. In concerning the adverse event, so the adverse event were evaluated also in SOLANGE study, which was also exploring the PK, the PK-APD for this molecule. As you see here, summarized 84% were grade 1 and 2, mainly headache, nausea, back pain, and the experience of the infection was similar for this patient to what was already reported in the literature, in the folder, in the clinical folder of this patient, and there were no events related to bleeding that might be connected with the treatment. This is an additional information that is very interesting due to the fact that P-selectin is present on platelets. Then we have, of course, the chapter of gene therapy, which is under consideration and discussion in patients with sickle cell disease. Up to now, 2 different strategies, main strategy are available. One is the lentivirus, and we have data from lentivirus identical to that used in patients with beta thalassemia, showing that, of course, there is a result even in this patient concerning the expression of the mutated, the transfected hemoglobin with the clinical manifestation that are, expected due to the conditioning and the transplantation. The major discussion concerning lentivirus approach were related to the recent leukemic cases that have been under consideration and discussion by the company, which come out with no correlation, apparently no correlation with the strategy and the appearance of this case. Very promising is also the approach in CRISPR gene editing in sickle cell disease targeting BCL11, which is involved in the switch from fetal hemoglobin to adult hemoglobin, as you can see here. And this is related to a publication in the New England on 2 patients, one with thalassemia and the other one with sickle cell disease. And in this slide, they summarize the results concerning the expression of the different subtypes, of hemoglobins. And you see a fetal hemoglobin, which is rising after the treatment, and you see running from going from 25.9% to 43% on the time of observation. And this was also associated with an increase, a marked increase in the number of red cells that were present into the peripheral circulation, with apparently a positive impact on clinical manifestation of sickle cell disease. So when we think to clinical management of patients with sickle cell disease, we have to think really to a broad spectrum of clinical manifestation, going from acute events to chronic sickle cell related complication that may deeply affect patient quality of life and, of course, survival. So novel treatment should be directed to modify natural history of the disease, so to interfere both with vaso-occlusive crisis, but also with chronic organ complication. And of course, quality of life should also be considered as part of the outcome in clinical studies, and also in considering the efficacy of any treatment for sickle cell disease. And I thank you, and I'm here for any questions.
Thank you, Dr. Franceschi, for the very informative presentation. We'll leave the questions for the end. We'll proceed with the next presentation. We're very happy to have Dr. Adlet Inadi, who is a professor of clinical medicine at the Lebanese American University and is also the director of comprehensive sickle cell program at Nini Hospital in Tripoli, Lebanon. Dr. Inadi will be giving us an overview of the care and cure of pediatric sickle cell disease patients.
Thank you, Katia. Let me start by congratulating TIF for all its initiatives over the years and for thanking the organizers, Dr. Eleftherio, Mr. Iglesias, and Dr. Angustinotis for their kind invitation. I think Dr. Lucia made my mission much easier because she's probably spoke about maybe 50% of my presentation, but I'll try to get targeted to children. Can I share my presentation, please? Okay, great. Okay. Okay. This is my disclaimer. So what I plan to do today is to briefly review sickle cell disease pathophysiology, briefly navigate through disease complications in children, cover standard of care, review curative and novel therapeutic modalities, and try to review the ASH 2020 guidelines supporting some of the knowledge given. So I know that's straightforward for most of you. Sickle cell disease, as you know, is an inherited lifelong hematologic disorder characterized by chronic hemolytic anemia, vaso-occlusive crisis, and end organ damage. Even though it's monogenic, but it's clinically heterogeneous with significant morbidity and mortality, and sadly, with up to 80% of mortality in early childhood in low-resource countries. However, as you've heard before from Dr. Lucia, with a deeper understanding of disease pathophysiology, sickle cell disease research has recently translated into so many novel drugs and potentially curative genetic therapies. Very briefly, in terms of pathophysiology, get my pointer, okay. So we all know it's just a single mutation. Subsystem valine for glutamic acid results in a sickle hemoglobin. And this under the oxygenation polymerizes, leading to the abnormal rigid sickle cell shape that dies prematurely, leading to hemolytic anemia, and occludes microvascular, leading to vasoocclusion. So it's the vasoocclusive crisis, the organ damage, and the fatigue that are characteristic, but the most important thing is the downstream effect of vasoocclusion and hemolysis, which really take into consideration a lot of inflammation, coagulopathy, adhesion molecules, which are responsible for the pathophysiology of sickle cell disease. But regardless, vasoocclusive crisis remain one of the most debilitating manifestations in children with sickle cell disease. And as you see, the process is not as simple. It's not just polymerization per se. It's what comes with upregulation of adhesion molecules, inflammation, cell activation, multicellular adhesion, and the recurrent vasoocclusion that leads to tissue and organ damage. And this variable pathophysiology underlies the rationale for multimodal therapy and many of the novel drugs in sickle cell disease. And what we see really in the clinic is just the tip of the iceberg. We see these children coming with severe excruciating pain, but we have to think of what's below, which is way more serious, that recurrent vasoocclusion over time, that multicellular adhesion, that inflammation, activation, endothelial damage. This is what results in organ damage. And this is what we as healthcare providers and hematologists, mostly in the pediatric age group, should be very careful about trying to arrest, if possible, or minimize the impact of organ damage in the disease. And the vasoocclusion complications really appear very early in childhood. The earliest with the dactylitis, where there's painful, tender, swollen hands and feet. The spleen involvement, that sudden drop in hemoglobin with a huge acute spleen sequestration, which remains one of the commonest causes of early mortality in sickle cell disease, but which is preventable with patient education, or at least minimize its impact minimized. And that with recurrent vasoocclusion, there's splenic dysfunction, and that underlies, it's one of the major reasons for the severe infections, particularly with encapsulated organisms. So these two, really, we see a lot of infections, still acute spleen sequestration, and we need to prevent those. Lung can be involved, acute chest syndrome, brain with stroke, be it silent, or the penis can be involved with priapism. And of course, pain is the hallmark in every age group. But it's very important to realize that there are so many unrecognized consequences to vasoocclusion, and these really underlie some of the silent causes of death or morbidity. The eye could result silently in retinal involvement and silent blindness. So is the kidney, so is the liver, and so are the bones. So really, it is not a matter of vasoocclusion, it's not a matter of pain, it's a matter of multi-system involvement, a very complex disease. And then when we think of treatment, we have to think of the pathophysiology. But regardless, pain is the most common complication beginning in early childhood and spanning the life course. It is the first cause of healthcare utilization in children and also in adults, associated with significant morbidity, negative impacts on patients' health-related quality of life. Typically, these children present very acutely. It can be very severe, but can be chronic, especially when they advance in age. It can involve any body organ, and the recurrence rate is high. And the higher the recurrence, the more risk of complications and organ damage and death, and is associated with inflammation. There are certain triggers, known triggers like cold, stress, illness, or dehydration that families need to be aware of. So when you talk about care of children with sickle cell disease, we need really to have specific goals, like any care program. Our goals should be to reduce symptoms, prevent and manage complications, and as pediatric hematologists, prevention and early detection are the key. Improve quality of life and prolong life. And the standard of care remains really the standard of care. And this is an important part of the management of sickle cell disease, and the most important part, actually. Comprehensive care, pain management, hydroxyurea and transfusion, and curative therapy you've heard about, and novel drug therapies has been very nicely touched upon, and I will touch upon it later on as well. In order to be able to be well treated as a patient with sickle cell disease, the treatment should be conducted in a comprehensive setting. which is patient-friendly, where they coordinated interdisciplinary team, and not only hematologists, not only nurses, not only clinical psychologists and more than one specialty doctors. It's really the social workers, it's the lab, it's the educator that are extremely important. When I think of a sickle cell disease comprehensive care program in pediatrics, I would think of these 4 key elements: newborn screening, prevention of infections, early detection and treatment of complications, parent and patient-centered education. So if you notice, it's early detection and prevention, always in pediatrics. It has been known for so many years and presented by Vyshtinsky that if you diagnose babies with sickle cell disease in the newborn period, the survival is significantly higher than those diagnosed after newborn period. But it's not enough to diagnose. That diagnosis has to be followed by preventive therapy to minimize sickle cell disease complications. And one of those important preventive therapies is prevention of infections. And this is done by supplying oral penicillin, prophylactic oral penicillin by 4 months to at least 5 years of age, and routine childhood vaccines, including those against encapsulated organisms, H. influenza, pneumococcus, meningococcus, and yearly influenza vaccine. We need to remember, children are children. They should receive all the vaccines, but in addition, an emphasis on those vaccines is extremely important. And stroke, as you very well know, is one of the most devastating and early complications of sickle cell disease. And it has been known for a long time and reported by Adams in STOP trials that all children should be 2 to 16 years of age should be screened by transcranial Doppler. And those who have very high velocities have a very low probability of remaining stroke-free, meaning they are predisposed, highly predisposed to developing stroke. But if those receive regular blood transfusion, that has been shown be it in Europe or the US to result in a significant reduction of stroke. And in the past, screening for silent reinfarction, developmental delay, and cognitive impairment has received attention, but not enough. And this has been addressed in the ASH 2020 guidelines with the recommendations of at least a one-time MRI screening in early school children, and conducting surveillance for cognitive impairment, developmental delay, and neurodevelopmental disorders by caring physicians, and those who have abnormal results to be referred to a psychologist or even a trained pediatrician, and to have appropriate intervention if needed. And education of families and young adolescents is very, and even children, is very extremely important, particularly regarding what are the life-threatening disease symptoms and when to seek emergency care. Fever, because these patients are immune compromised, increasing pallor, refractory pain, chest pain and dyspnea suggestive of acute chest syndrome, any symptoms of signs suggestive of stroke, sudden change in vision, and let's not forget acute splenic sequestration, which is still a killer in infants all over the world, and priapism. So when we talk about pain, in children, even though they may have chronic pain, but most of the time they do have acute pain, and this is why I want to concentrate on acute pain management. Let me start by saying there's significant variability and paucity of direct evidence, despite the fact this is a very devastating complication of sickle cell disease. We need to emphasize that because it's so variable, the pain presentation, intensity, and progression, no one-size-fits-all approach to optimal pain management. We need to individualize our patient. We need to give patient-centered, interdisciplinary pain approach, and this is the key. And we need to anticipate and treat complications because this can happen very suddenly, and children can die within half an hour to a few hours, even in the hospital, if you do not have a high index of suspicion. Acute chest syndrome, multi-organ failure. So basically, it has been mentioned earlier, rapid pain assessment and administration of analgesia in the emergency department within 1 hour at most. Reassessment every 30 to 60 minutes for optimal pain control. If opioids are indicated, they're tailored to previous opioid effective therapy and to baseline opioid therapy. NSAIDs can be given coupled with opioids. Steroids, there's no room for steroids and straightforward treatment of acute pain. Ketamine adjunctive treatment can be given for those refractory or not effective treatment with opioids alone, and for those with stubborn local pain, regional anesthesia can be considered. There's more emphasis nowadays on non-pharmacological therapy in addition to standard analgesia drugs. And what's most important is to have these patients not wait in the emergency room, but being treated in sickle cell specific acute care facilities and not in the typical ED emergency room basis. And above all, some people tend not to believe patients. We need to believe patients, avoid considering opioid requests as a drug-seeking behavior. And hydroxyurea, again, Dr. Lucia talked about it very in an excellent way. This is, again, to me, at this point in time, despite all the novel drugs, it remains the only sickle cell disease modifying treatment because it has really been experienced by patients for more than 20 years. It's a ribonucleotide reductase inhibitor with multiple beneficial effects. If you look at the right, it really targets more than one pathophysiology of sickle cell disease. So it's not only related to one etiology. It induces hemoglobin F synthesis, so less sickling, better red cell survival, it decreases cellular adhesion, inflammation, and what the patient and family sees are those complications. It reduces short-term vaso-occlusive crisis, hospitalization, transfusions, even the TCD measures, and long-term organ dysfunction complications. Sadly, it's still underutilized, and the exposure is often inadequate. Some patients, not many actually, have myelosuppression, suboptimal response at maximal tolerated dose, as people are unwilling to use due to concerns about mutagenesis and long-term effects. And that drug has been really very robustly studied across all age groups. The multi-center study of hydroxyurea in adults, the HUGSKIT study in children, the baby HUG trial in infants, and all of them have shown the efficacy of this drug in preventing major complications of sickle cell disease, in improving lab parameters with a good safety profile. And based on the baby HUG trial, the National Heart, Lung, and Blood Institute has really recommended that hydroxyurea be started in infants as of 9 months of age, regardless of severity. But the problem remains that even if patients do receive what we think is an optimal drug, optimal dose, or a higher dose of hydroxyurea based on the maximum tolerated dose, still they could be underdosed. And this is the reason why the hydroxyurea optimization through precision study was initiated. And the idea is to validate feasibility and benefits of a hydroxyurea PK-guided dosing approach in participants 6 to 21 years of age. So what about transfusions? Let me highlight that transfusion in sickle cell disease are different from thalassemia, whereas all children with transfusion-dependent thalassemia need transfusion and chelation, and if lucky enough, curative therapy, hematopoietic stem cell transplant. In sickle cell disease, this is different, and transfusions are indicated for selected patients. They do play an important role in treatment and prevention of acute and chronic complications. As pediatric hematologists, we tend to use them more as single transfusion indications, acute spank sequestration, acute chest syndrome mostly. But the only evidence-based indication for giving long-term chronic transfusion is prevention and treatment of stroke. True, we can give them sometimes for refractory pain, acute chest syndrome, but that's not the main indication. We've talked about cerebrovascular disease before. I've talked about annual TCD screening, and if abnormal, the new ASH 2020 guidelines highlight if there a variation or difference from previous guidelines. If children are living in high-income setting, they can take transfusion for at least a year to keep hemoglobin as less than 30% and hemoglobin above 9 grams per deciliter. And after 1 year, family is interested in stopping transfusion, but provided that there's no vasculopathy and no silent cerebral infarction, hydroxyurea treatment at maximum tolerated dose can be a substitute. So we're not saying now everybody should be on chronic transfusion for life indefinitely. There's a little bit of variability, but again, these patients should be free of vasculopathy. If they're living in low middle income countries, and remember, 80% of people with sickle cell disease, if not more, do live in low resource countries. So hydroxyurea, and the data has been very clear in more than one study that hydroxyurea, at least 20 milligrams per kilo per day or fixed dose can be given. For secondary stroke prevention, the only treatment is blood transfusion indefinitely. And for anybody presenting with an acute neurologic event, that's transfusion within 2 hours of presentation. Can we give it? Can transfusions be given to prevent and reduce pain, recurrent pain? No. Actually, the panel was against chronic monthly transfusion as first-line therapy, except if in very refractory pain, a trial of monthly transfusion may be reasonable if shared decision can be applied. What about preoperatively? You often see patients, children transfuse preoperatively. No, the indication is for surgeries requiring general anesthesia more than 1 hour, not for any minor surgery and not for local anesthesia for sure. How do we transfuse? Red cell exchange transfusion is the option, is the best modality for those requiring chronic transfusion for ACS, but in simple or moderate ACS, simple transfusion can be given as well. So you've heard transfusions are effective undoubtedly in management of acute and chronic complications, but they're associated with major adverse events, particularly in sickle cell disease, and it's the alloimmunization, the hemolytic transfusion reaction, and the iron overload. And for us, alloimmunization is a nightmare. So it's extremely important to reduce it and prevent it. So before the first transfusion, we need to give extended red cell antigen profile, minding that economic resources may not allow this, but these are the recommendations. For those receiving transfusions, prophylactic red cell antigen matching. And the most important message, do not give transfusion, except if really, really necessary. And that these patients be transfused in a dedicated center, sickle cell disease center, and not in multiple healthcare centers. And if somebody develops hemolytic transfusion reaction, be it acute hemolytic transfusion reaction or delayed, what to do? Generally, the treatment is immunosuppressants. If you give chronic transfusion, an inevitable consequence is going to be iron overload. In sickle cell disease, in contrast to thalassemia, generally, iron overload is not really recognized. It's underdiagnosed, undertreated. We know also there's a difference in iron-related organ dysfunction in sickle cell disease. We reported that, and others have reported the heart and the endocrine organ seem to be more spared than compared to thalassemia at comparable levels of liver iron overload. However, as survival in sickle cell disease is increasing, iron-related complications are expected to increase. So unless effectively treated, iron overload is going to result in severe organ damage and life-threatening complications. Luckily, there are many effective chelators, iron chelators now, some of which are oral, and these have resulted in excellent treatment of iron overload. I will not go over that because Dr. Shia has mentioned that very well. I would like just to emphasize that the best results overall survival, event-free survival up to 94% and 92% are in matchful SIB donor transplant. And even though, with reduced intensive conditioning, improved use of alternative donor and novel methods of GVHD prophylaxis, hematopoietic stem cell transplant may become more widespread, but this is really very costly as well. So the whole transplant is limited by low availability of matched donors, not more than 20 to 30%, even in large size families like the Lebanese families, risk of transplant rate, morbidity, and mortality. So if we're going to transplant, let's transplant those who need them. Neurologic events, frequent pain, recurrent ACS, and alloimmunization. And earlier in life, that is the message. If we're going to transplant, let's do the matched living donor transplant earlier in life, before onset of irreversible sickle cell disease-related damage. So from what I've shown you so far, with all these disease-modifying therapies, most of them really could be not expensive, maybe except for a transplant for sure. survival has significantly improved. And that's actually an old slide from Quinn comparing the Jamaican cohort that did not have access to any disease-modifying therapies to the modern Dallas and also England, London cohort, and the difference in survival is significantly different, with an overall survival at 18 years of age projected to be around 94%, and in the severe cases, SSS beta 0, and almost 100% in the other genotypes. Even though burden of mortality, even though survival is improving in children, however, burden of mortality is increasing, shifting in adults, and particularly in the transition period, where these people are very vulnerable and they start dropping their visits. In Africa, sadly, only 20% of children survive their second birthday. For novel therapies, I'll quickly go through them because I think they have been really covered very nicely. Our deeper understanding over the past 2 decades of the sickle cell disease pathophysiology and the several unmet needs in the treatment of sickle cell disease have been the driving forces for this evolving pharmacotherapeutic landscape. At least 50 new drugs are being studied, again, targeted to the pathophysiology, hemoglobin F production, adhesion, polymerization, oxidative damage, inflammation. 3 categories, some have failed, some are being actively studied, and some are FDA approved. And because this is a pediatric, I'm talking about care in pediatrics, I'm going to highlight Voxelator, not to undermine that crizanlizumab has really, all of them have received FDA approval, all of them have been very well, and are on L-glutamine, the long-term data showing that even in VOC, but it's not only children actually, the results in VOC reduction are comparable to those with crizanlizumab and also hydroxyurea. But I'll highlight Voxelator because it really has been FDA approved for younger children, more or equal 12 years. And it has been still being undergoing a lot of studies. You're all aware that efficacy and safety of the previously document of Voxelator has been previously documented in adolescents, adults with sickle cell disease. It's a hemoglobin S polymerization inhibitor. And now the studies are mostly ongoing in HOPE Kids, which is a phase 2A open label multiple dose trial to evaluate PK safety and efficacy in pediatric patients. And the data we have presented in EHA this year and will be presented in ASH. And as you see here, around 1 gram per deciliter increase has been seen at week 24 in mean, and around almost 50% of patients achieved a hemoglobin response defined as more than 1 gram per deciliter hemoglobin increase. Of course, because it targets hemolysis as well, there's a decrease in the hemolytic markers, be it bilirubin, LDH, and reticulocyte count. So treatment with Voxelator may have potential to modify morbidity and mortality and end organ function, particularly that a lot of the end organ function is linked not only to vaso-occlusion, but to hemolysis. And there are so many ongoing trials targeting every single pathophysiology, multi-cell adhesion, endothelial blockage, like, in kids, the Solis kits, there's the steadfast for the kidneys. There's also another study for priapism. There's now the GBT, another P-selectin inhibitor, also ongoing in children and adults as well. And there are drugs targeting RBC hemolysis, pyruvate kinase activator, FT422, oral ferroportin inhibitors, phosphodiesterase inhibitor, and also more work done on HOPE Kids as well. So lots of studies are ongoing. Gene therapy. Gene therapy, the idea is really either involving introduction of new genetic material to compensate for an abnormal gene as beta globin gene, or do what we call gene addition, or gene editing, which is reverse silencing of the fetal globin gene, BCL11A gene, to increase expression of fetal hemoglobin. So what are its advantages? You use patients' own blood cells. You don't have to worry about a donor. Decreased need for immunosuppressive drugs and risk of graft versus host disease. It is costly, however. It is not widely available at all. And there's still, as Dr. Lucia has mentioned, concerns about mutagenesis and infertility. This is the first, one of the major studies. This is the lentiglobin as gene addition therapy. And if you see the preliminary results that have been presented in EHA and ASG, more than 70% of subjects studied have shown an improvement in the RBC containing therapeutic hemoglobin, meaning that RBCs are containing the normal hemoglobin. The annualized VOC and acute chest syndrome have improved by at least 90, almost 100%, and there was decrease in hemolytic markers. And as of data cutoff, there were no treatment-related events. And if you look at the right, you see the VOC, no severe vaso-occlusive crisis. There was complete resolution and transfusion-dependent normal hemolytic markers. So preliminary data are promising. And this is the other modality, the edited stem cell therapy, using the autologous CRISPR-Cas9, which means that you do a break, a DNA double-strand break in the BCL11A gene, which is known to be a gamma globin inhibitor. That results in increased hemoglobin F production, and we know increased hemoglobin F production is going to minimize polymerization and hemolysis. And the outcomes so far of these studies have shown durable increase in hemoglobin F, normalization of hemolytic markers, no VOCs, and also evidence of this edited allele in the CD34 bone marrow cells have been shown. But again, these are preliminary long-term data and is important, especially about adverse events. In as much as efficacy is important, but the safety is still a concern. So in summary, care of children with sickle cell disease is really complex and entails a patient-centered and interdisciplinary multimodality therapy with prevention and treatment of complications as an important priority. Greater understanding of the pathophysiology of sickle cell disease had led, as I've shown, to safe and efficacious agents and therapies that can be used in combination. So we'll talk about combination therapy, like we're talking about combination chemotherapy in cancer. But amidst this new therapeutic era, I think we need to rethink and optimize all drugs and therapeutic approaches as hydroxyurea, transfusions, and hematopoietic stem cell transplant that have withstood the challenge of time and showed their efficacy. Hydroxyurea continues to have tremendous potential globally and to replace blood transfusion in select cases in children with TCD, as I've shown you. But again, the main challenge remains as healthcare providers and as scientists is to render care and cure for children with sickle cell disease globally available and affordable. Thank you so much for your attention.
Thank you so much, Dr. Rinaldi. Very informative. Now, as Dr. Angustinotis had emphasized earlier, and Dr. Rinaldi had mentioned, education is essential. So TIF has developed a course on sickle cell disease for healthcare professionals and is also towards the completion of the development of a sickle cell disease course for patients. Dr. Katsounis, who is a clinical pathology and laboratory medicine consultant at the Blood Center of Aheba University Hospital in Thessaloniki, Greece, is currently working along with Dr. Yartumian in completing the development of the content of the sickle cell disease course for patients. Dr. Katsounis will now provide us with the learning objectives and the added value of this course for patients. Dr. Katsounis?
Hello.
Hello.
I will share my presentation. I think you can see it, right?
Yes, yes, thank you.
Okay, so good afternoon from me. First of all, I would like to thank TIF for giving me the opportunity to be involved in such an important project. And I will speak to you briefly about this e-academy that TIF is developing. So this is an educational online platform, obviously run by Thalassemia International Federation, and it works in a self-paced mode. So someone can enroll and attend the platform and on his own pace as he wishes. So this platform is designed both for healthcare professionals and for patients with hemoglobinopathies. Of course, this means that it has two different modules, one for the professionals and one for the patients. The platform is by design meant to be available in multiple languages, and material that exists already for thalassemia is available in all the languages that are listed in the slide. So there is a module for thalassemia, which is one part of it is of course addressed towards healthcare professionals, and the other one is addressed towards patients. So TIF has already developed part of the platform for healthcare professionals about sickle cell disease, and this will be the topic of the next presentation. So I will show you a little bit about the e-course for sickle cell disease patients, which is under development, and I believe we're not very far from releasing it. So this is an overview of the e-course for patients. There is an introduction regarding sickle cell disease, and then there are chapters for various clinical complications, as you can see listed in the slide. So for each one of them, there is a short presentation in a small PDF file that has all the information that are relevant for patients. There are also information about treatment options like blood transfusion, hydroxycarbamide, and newer treatments. Of course, someone can download the standards of care that are written in the UK. And this platform is essentially a part of an expert patients program. And the last few years, we can see that there is a fundamental shift in the way chronic diseases are perceived and managed. So patients should play a key role in their management. They should be involved as equal partners in the decision-making process. And through their experience, they can help in the improvement of healthcare services. But for this to happen, patients have to be fully informed. Patients should know about their condition. They should know about its holistic care, and they should also know about their rights as patients and citizens so that they can participate actively in this process. The Expert Patients Program aims to extend quality disease and treatment-related information towards patients across the world. It aims to enable patients to take valuable, meaningful decisions about their health. So patients will be well informed so that they can collaborate with their clinical doctors and let's say participate in their treatment and be knowledgeable about their condition. And this program is directed toward patients with hemoglobinopathies, their parents and carers for younger patients, and of course it will be very helpful for advocacy groups. I will show you a small preview of the platform. This is how the platform looks like when you log in. So this is the section for patients. There is already the e-course for thalassemia patients, resources, webinars, and there will be a new button that will include the course for sickle cell disease patients. So now I'm just going to show you a preview of a few selected slides that I put together so that you can get an idea of what to expect, of how it is written, and the layout. So here you see the slide from the introductory module, where you can see short information about sickle cell disease. And for example, this is a slide from the acute pain crisis. So you can see some photos and some information about children and adults. A slide from the acute chest syndrome. So we can see a couple of x-rays and short information about the condition. A slide from the kidney section. Priapism. So here you can see that patients can get short targeted information about this condition and let's say what to do, a kind of guide as to what a patient could do to help himself get treatment as soon as possible, and of course to recognize the condition. Types of transfusion, so short information about exchange transfusion or simple transfusion, how it's done and what is its purpose. Hydroxycarbamide, information about what it is and why it's taken. Short information about new treatments that are upcoming, like gene therapy. So to sum up, the learning objectives are the explanation of the pathological conditions in sickle cell disease written in a language that is suitable for patients to comprehend, and not with a lot of heavy medical jargon. Practical guidance on the management of sickle cell disease, what patients should know, how to recognize various conditions and how to handle them, and how to seek help from professionals. And the platform aims to elaborate on current and new treatments so that patients will know about treatments that will appear on their way in the near future. The added value is that patients will become well-informed. They will become able to participate in the decision-making process regarding the treatment. So they will be more effective in, let's say, self-management, of course, always under the guidance of professionals. They will gain confidence and understanding instead of fear and anxiety over their condition. And hopefully patients will be able to exert better and more effective advocacy by knowing their needs and explaining them properly to local decision makers. These are some valuable resources that are available online, and an important part of the platform has been based on these resources. So they are the standards of care, both for adults and for patients in the UK, recent publications. And Dr. Vardumian has done a lot of work. I think she has done most of the work, and she should take credit for this because she's done a really good job. So that's all from me. I would like to thank you.
Thank you, Dr. Kaltsunis. Okay, now I would like to introduce you to Dr. Yartumian, a consultant hematologist. Dr. Yartumian is the medical expert who has coordinated the development of sickle cell disease course for healthcare professionals, along with Dr. Lukopoulos, besides her work with the patients course. Dr. Yartumian, besides coordinating that project for healthcare professionals, she also served as one of the authors and one of the reviewers. Dr. Yartumian will go over the learning objectives and added value of the healthcare course for the healthcare professionals on sickle cell disease. Dr. Yartumian?
Thank you.
I will share my screen. Yeah.
Good. First, an apology that you can't see me. We tried earlier on and I seem to have a technical problem with the camera on this laptop. So apologies for that, but we will be able to see my presentation shortly, I hope. And as Dr. Kaltsunis and Kati said, this is going to focus on the healthcare professionals platform that we were working on throughout last year. Largely. I recently retired as a consultant hematologist in a large red cell service in North London. Since my retirement, I've been kept pretty busy by TIFF projects and have enjoyed the collaboration with them, and hope that our educational materials will be useful both for professionals and for patients. So thank you for the invitation to present briefly some of our learning objectives and hopefully the value of the platform. Next. You all know, I'm sure, and we've heard a lot already about the complexity of the condition that is the long-term, lifelong indeed, condition that is sickle cell disease. It obviously is already disruptive for most children and adults who are affected by it, in that they are having to prevent and manage the risks from infection. They will nearly all have to manage some pain episodes, and they will all need to attend clinics for monitoring. The organisation of care can be really challenging, and I'm going to talk a bit more about that. Some simple, uncomplicated problems should be managed at home with support. They do need support and education from well-informed healthcare professionals. And where it's not possible to manage problems at home, where pain isn't manageable with simple oral analgesia, for example, local hospitals should be able to manage those problems. The problem really is that even seemingly simple complications, such as a pain crisis, can rapidly evolve and deteriorate into a much more serious complications, such as acute chest syndrome. There may be stroke in the setting of a pain crisis, etc. So a very close monitoring with the ability to escalate care is necessary, even for relatively simple seeming presentations. There are a number of much less common complications. So, for example, acute liver problems, and obviously stroke we've talked about, which need urgent and highly specialist healthcare management. And most teams in local community or small hospitals won't be familiar with these sorts of presentations and their management. Next. So ideally, everybody affected by the condition would be supported by knowledgeable local healthcare personnel. They'd have access to a local emergency facility for management of frequent complications, so not having to travel far. And they would all have access to a specialist sickle cell centre for the management of acute and chronic complex presentations, and management during particularly vulnerable times such as pregnancy and delivery and complex surgery. And in the ideal world, their community, local and specialist teams would all be linked together and have clear communication channels to optimize their management, working across a network. And we've heard from Dr. Franceschi and Dr. Renati a lot about what we hope can be delivered by such expert healthcare centres for sickle cell. Next. The big but, of course, is that this model of care and indeed a lot of the complex sorts of interventions that we've had described during our earlier talks is available only in a relatively few high-resource countries. And for example, in England, it's made relatively simpler because most of the affected people live in a relatively few cities, urban centres, and specialist services have therefore developed around those populations. But we know that the majority of affected children and adults across the world currently live in large countries, across large countries, not in specific areas, but in very widespread areas of large countries where services are often challenged by being under-resourced and where they will be competing with a wide range of other difficult healthcare demands. And for many affected people, children and adults, specifically knowledgeable, experienced and skilled professionals will not be readily available to them. Next. So there has been discussion about how TIFF may be able to help try and address some of these difficulties and the resulting inequities of care standards, of course. And our joint conclusion was it would probably be helpful to make an educational platform for healthcare professionals, which was easy to access, generally easy to access, and applicable for widespread use. we agreed that the guidelines should be based on available published care guidelines, while noting that few publications have a really practical focus, giving specific stepped recommendations about care interventions. So we have tried in our platform to give the content a practical focus and have in each section enumerated specific recommendations. Most of the recommendations can be applied in a range of settings. They are not on the whole highly complex. They're more about careful monitoring and when to intervene in various ways, but they don't presume a very high level of resource. And some where, for example, regular safe transfusion may not be available for people in terms of stroke prevention, do have include approaches in lower resource settings. So the guidance, the content is largely clinical. It has got some pathophysiology and theoretical background really by way of explanation to make sense of it. But the focus is not academic. It is on clinical management, but also on organizational approaches to try and manage patients who don't have access to this sort of expert or specialist center where they can get the optimal care that's been described. Our target audience, I've said was, because we may be able to use it in a different way that I'm going to come back to, but the original target audience was trained medical and nursing personnel working outside highly resourced specialist centers. It's assumed in the specialist centers there will be internal education programs, etc. So this was really to make available educational material for people working outside those centers. And we hope that they will use the platform for personal education, but also for practical guidance on management of clinical presentations as they arise, because it would be possible to see a patient concern of priapism, for example, in emergency department. And if you weren't personally expert, you could go to the chapter and be guided about how you might approach the care. So while practical guidance is included, it is everywhere stressed that linkage with one or another specialist centre will be necessary on occasions. And it's acknowledged that in some places referral into a centre will be possible, and that's ideal, but in many places that will not be possible, but that linkages should be set up with a specialist centre team for such advice in and out of hours at all times. And we know that pretty much everywhere where there's a will, such communications can take place, obviously with mobile phones and internet connections. Next. And this is just a couple of quotations from the organisation section before I come on and show you some of the content. Key requirement is that all healthcare teams establish their working partnerships with the appropriate centre. And a comment which people may challenge, but I think it's probably reasonable to say direct care by specialist staff is ideal. Care given by less specialist staff who are receiving step-by-step guidance and support from experts in sickle cell disease management can also have excellent outcomes. And I'm sure we've all got examples in mind of people who we've managed remotely when they've been out of our area and being managed by a less specialist team, but where people are seeking advice on a sort of sometimes hourly basis with updates. So now some snapshots of the course itself. The next slide just shows us the front page of the course, which Katia is going to kindly call up for us. It was actually on my next slide, if it's there.
Hold on, I will share my screen again.
You could just put up the next slide if there's a delay. Okay. Thank you. So as you log into the course, this is the front screen that comes up with a little bit of an introduction. And then if you go down a little, Katia, just to show the sections, and I'm going to go through these in turn. There are 4 main sections. I'd like just first to go to the acknowledgements page, if I may. Thank you. The TIF directors invited Professor Loukopoulos in Athens and myself to co-edit this work, and we enjoyed a very fruitful, I hope, and certainly enjoyable collaboration throughout last year. Listed below there are the other 19 authors that we invited to author or co-author one or more chapters. The authors were from France, from Greece, from Lebanon, and from the UK, and their names and are listed there with their organizations. And below that, there's a list of helpful colleagues of mine from the UK mainly, who reviewed the draft content. Always helpful to have external pairs of eyes. The two names that are not on this acknowledgement slide, and I feel sad about this, are both Katia herself, who was enormously helpful in pulling this together and coordinating the work, and Martha Vassiliadou from Genestial, which actually does appear on the front slide, who are the organization who put together the presentations in the format that it is. And I'm going to try and show you some of those because I think you'll find them quite attractive and easy to use. So the content first of the introduction is background. It's you can use all of these sections independently. So as I say, if you happen to be faced with a specific clinical problem, you could go straight there, but it is recommended that you read these by way of background first, because obviously it makes quite a lot more sense if you understand the pathology and pathophysiology. So there's one on genetics, epidemiology and pathophysiology. We won't go into all of these, obviously they're too numerous. Then there's one on screening and prevention programs, and one on laboratory tests. Not everybody will want to read all of these, but they're available for those that do. And then if we go on to the second section.
Sorry about that.
It's actually very, it doesn't look as if it is, but it's very user-friendly and easy and stable actually when you're using it. So here we're going to chapter the section 2. Thank you. And just by way of example, I'm going to ask Katia if she'll open up the 2.3, which is about respiratory complications. Thank you. And listed here are the contents, and first and foremost, of course, we've talked about acute chest syndrome. So we're just going to scroll down a couple of pages of this to show you the kind of layout. It's not coming up as it actually does in a sort of phased way, but you can see there are some clinical pictures, x-rays of acute chest syndrome there, and scrolling on down, we talk about investigation, predictors of severity, keeping on going. There are various techniques we've used so that not everybody, just scrolling down past obviously the background biology of the problems, but not everybody will want to look at every single section, and methods of allowing people to skim over, thank you, just stop there a minute. Sections are what is called an accordion, so that there is a list of different contributory elements, and if you click on one, it will give you much more detail about that. So if you want to know about it, it's all there, but not every reader is obliged to go through every word. And there's in other sections, thanks very much, Katia. If you just go down to the recommendations section now. In other sections, there's a different device which allows, they're called appendices. So for example, in the transfusion chapter, there is an appendix about the specifics of laboratory transfusion medicine as applied to sickle cell, recognizing that if you're a specialist nurse or a generalist doctor or pediatrician, you may not actually want to know about that, but some people will. So the recommendations, as I've said, they're quite numerous in this chapter because obviously it's complex, but you'll see they're quite specific about the degree of hypoxia, which should trigger what sort of interventions and so on. Okay, thank you. If we go back, you'll see actually at the end of every recommendation section is an invitation to comment. So we'll carry on now to the next slides. That's fine, yes. Can you just go back to the content of the sections 3 and 4? So here's the treatment sections. I mean, none of this will be a surprise. So section 2 is the longest. It has each individual organ by chapter. Here we talk about transfusion, management of iron overload, hydroxycarbamide, and then the organization section. Yes, you can go to that one now, thanks. It attempts to address the difficulty in different sort of healthcare settings. There's an annual review form, which is something we very much favor in the UK for children and adult outpatients, and a guide to the sorts of steps that would take there. And transition has been mentioned, and actually we wholeheartedly agree that's so important that it merited its own chapter. Thank you. Just the next slide now. So how best do we think this can be used? Well, as I say, the intention was that it was for individual study. Obviously, every healthcare professional, doctor, nurse, and others have an individual responsibility to make sure that they know sufficient information and seek it when necessary to manage their practice safely. So everybody has continuing professional development responsibility, and this is an attempt to help them with that. And as I've explained, the content allows for different levels of knowledge that individual professions require. And we hope it'll be used for practical clinical management reference as needed. Recently, we've had some interesting discussions with a couple of the networks in London, actually Professor Porter's network in the UCL and the Whittington, so that's North and Central London, have been discussing with us the possibility of using this platform across their network staff as a way of ensuring continuing education for different staff groups. And it's been agreed that we will work with them so that they can use the platform and individually assess how this approach works, and use it as a sort of pilot project to use the material, not as was intended in less specialist centres, but perhaps as a way of continuing medical and professional development for staff in specialist centres and networks. You'll have noticed along the way the EHA, European Hematology Association logo, and we were pleased to be given endorsement from EHA, which obviously, as well as the TIFF hallmark, adds extra credence and respect. Many people have asked, and we are actively discussing, how best we can assess when individual professionals have been through the course, that their knowledge is now at a level that we would find acceptable, so they have, as it were, passed. And the way in which that's assessed and certified is not yet, I think, fully concluded, but under active discussion. Okay, next slide, and then that's the end. Thank you. This is a sort of summary. This is drawn from the guidance, but I think it's unarguable that offering good quality care for people with sickle cell is essential and hugely rewarding for families, patients, and for healthcare professionals to get it right. The positive spiral that develops when people receive care from knowledgeable, insightful, supportive, and enabling professionals leads to confident expert patients who have the best chance of a good outcome. And I think I'd summarize by saying this platform, together with the patients in educational platform, is TIFF's attempt to support this aim. Thank you.
Thank you, Dr. Yartunimian. We are very grateful.
Okay, not at all.
Okay. And now we are very happy and very grateful to have Ms. Tessa Younger, who is joining us today at the early morning hours from her part of the world. Ms. Tessa is the Sickle Cell Disease Program Specialist at the Sickle Cell Disease Coalition.
Good morning and good afternoon to you all, I guess, depending on where you're joining from. We're very grateful for the invitation to speak today. And again, I'm speaking from the Sickle Cell Disease Coalition, and we've been so fortunate to have the Thalassemia International Federation as one of our members. And we're just really grateful to share a little bit about the work we're doing to support the international sickle cell community and ways to engage others. So without further ado, I know we're a little short on time, so I'll be quick with my comments, but just wanted to give some background and a brief presentation overview of the Sickle Cell Disease Coalition, what we're all about, and how we're working to conquer sickle cell. So just as some brief background, it's been wonderful to hear a lot of the references to the American Society of Hematology. As mentioned, I work for the American Society of Hematology and help support the Sickle Cell Disease Coalition, which was founded by ASH in 2016. ASH launched this really multifaceted sickle cell initiative, including the development of clinical practice guidelines. And one other critical point beyond just medical care and advocacy is also bringing together these various stakeholders that are represented on this call and that represent various different touch points within the sickle cell experience. So you'll see in the box to the right, the various groups and stakeholders that we see as really valuable in our initiative and in any initiative around sickle cell. We think that there's a place for government, federal partners, industry leaders, providers, public health groups, patients, researchers, and philanthropies. And we think that through combining all of these various stakeholders and leaders, that we can achieve the goals that are outlined to the left, which is amplifying the voice of the sickle cell disease stakeholder community and making sure that all of those perspectives are represented in the work we do, promoting awareness about all of the awesome efforts that are coming down from these various different perspectives, and then ultimately improving outcomes for individuals with sickle cell disease. I think the past presentations touched on this wonderfully about the patient being an expert in their illness and being able to be active participants in the disease care process. And that's something that we completely and wholeheartedly believe in. And so we want to really leverage the expertise of all of these different stakeholders to improving the outcomes and care for sickle cell. And one thing we wanted to note is we do think that advocacy and funding of these various programs is extremely important. And we know that there's a voice and a place there. So what we've decided as a coalition is we unfortunately cannot lead those advocacy and funding efforts due to our bylaws and different limitations on our scope, but we very much encourage stakeholders that are interested in leading those opportunities or exploring those opportunities or developing partnerships in that way to join within the coalition and collaborate and network with our other members to find those opportunities and lead those in another forum. So just to break down a little bit of where we are in our composition of the coalition and our members, to just kind of clarify, our membership is based on organizations. We love the individual advocacy, but we really are trying to convene and collaborate on what we can do as these larger organizations that are assembled and working internally. So we have over 104 organizations represented. As you'll see to the left, that's kind of a breakdown of our representatives and various stakeholders. We have a fair amount of provider, research, public health organizations, but also a fair amount of industry groups and patient advocacy groups, and then also some governmental and philanthropic supporters as well. And again, as you'll see, and you all know in the sickle cell community, a lot of times we cover many of these different stakeholders, but we definitely see a need for all of these to be represented and look to balance those out more in the future. On the right, I will highlight for you all the breakdown of our international and domestic membership. Historically, we've been fairly strong in our US representation, but we've been growing pretty rapidly in our international growth as well. Right now, we're just over a quarter international, but we have received exponentially way more applications to join from international partners, and we definitely encourage that and are excited to see that growth. So this gives you a little bit of breakdown of how we actually operate. Again, ASH founded the coalition, but we really want this to be a voice for the full community. So we've developed the steering committee that you'll see outlined at the top box over to the kind of dark gray. And that involves all of our steering committee or all of our coalition co-chairs and leadership, but also various organizations outside of ASH to help convene and review all of our applicants to make sure that it's representative of the full voice of the community and to make sure that our strategy is leading into that multifaceted, interdisciplinary, and really community-oriented kind of direction. The red boxes that you'll see outlined are the different bodies that we actually convene in meetings. So thinking of how do we actually meet and collaborate, we have bi-monthly meetings as a full coalition, and then within those 5 different working groups and task forces listed there, that's access to care in the United States, addressing specific barriers that we have domestically, but we also have a blood donor diversity group, which talks about international issues of shortages in blood donations, and then also the need to have antigenic matching to make sure that you can have the best outcomes with your blood transfusions for people living with sickle cell. We also have a global issues group, which I definitely would highlight for folks on this call if you're interested in collaborating. That addresses a lot of the issues that we've discussed today and continue to discuss on the international landscape of sickle cell. And then we also focus on research and clinical trials and sickle cell trait most recently in addressing how do we educate folks and empower them to make the best decisions for their healthcare around all of these different areas. So here I'll more concretely dive into some past activities we've done and current initiatives that these various subcommittees and our full coalition are working on. In the past, we've really focused on leveraging different awareness days to launch campaigns and create a universal voice and a universal set of resources and social media information that folks can share so we can really unify the sickle cell community. And so we've done that on World Sickle Cell Awareness Days. In 2019, we focused on advancing access to care in sub-Saharan Africa. We released a global resources library, which I would highly recommend for you all to check out. We also did a blood donation awareness campaign in 2020. And then most recently in 2021, we had a Knowledge is Power campaign. So really empowering folks to learn more about sickle cell, especially people living with the disease, to take charge of their healthcare and to really lead their care decisions. We've also tried to do that throughout the year by collating partners' resources, as you'll find on the coalition's webpage. I've linked some of these great databases that I would recommend for you all to check out, including the Global Resources Library we have. And we've also developed a lot of great tools and information that, again, has been a collaborative effort from multiple organizations to help support and spread awareness. One great one I would also highlight for this group is we recently released a repository of global sickle cell disease educational tools. And so these are vetted, plain language, evidence-based information that breaks down various components of sickle cell. And the idea is that this is very basic. It can be adapted by anyone, accessed by anyone, and used anywhere for sickle cell education and tailored to your audiences. So those are just some past activities we've done and ways we've tried to offer support. And I'll focus now into some of our current efforts, which you'll see to the right. We have an Access to Care in the US working group that's focusing on supporting students with sickle cell disease. And we're actually developing an effort to have a whole web page of resources focused on educational supports for folks that are stakeholders in the educational space, but also students living with the disease. We've been doing a lot of work, again, with improving blood donation diversity recruitment. One thing I will highlight for this group, again, Global Issues Working Group, we are currently working on collating existing training and education resources in sickle cell care for healthcare providers. And then we're trying to identify what can be adapted, what could be used in low resource settings. So great example is TIF's e-course. And we're collecting all of these other examples of existing resources that we could consolidate and share to disseminate and have people access those more broadly. For the sake of time, I'll highlight some of these great resources to stay in touch with the coalition and to keep learning as we share information. Again, as I mentioned, we have on our website a lot of awesome resources and collated pages that I would recommend to check out that gather information from multiple organizations. We have a monthly e-newsletter update that shares information. Folks can sign on to receive that. And we also have a Twitter account that I would highly recommend you all to follow. It's @ConquerSCD. And lastly, before I close out, just wanted to share that we recently released this Scdc Snapshot fact sheet, which provides an overview of kind of what the coalition is all about and also shares a little bit of how we're trying to reorient, which I'll highlight here on that little text that's pulled out. We're really trying to focus our efforts on being a coordination hub for all of these folks that are stakeholders and invested in sickle cell advocacy and improving care. And I think that includes many of the people on this call. And so what we would really like to do is identify what is currently happening in the field and map that out so we can make sure we're not duplicating efforts, we're collaborating effectively, and we're making the most bang for our buck for the people living with sickle cell. And so to best organize, we plan to do this around the 2020 National Academies of Science, Engineering, and Medicine reports sickle cell disease strategies. And we've actually adapted these to be applicable to international settings that are affected by sickle cell. So I would definitely encourage you all to check out that fact sheet, learn more about the coalition. It's available on the coalition's webpage under About the Coalition. And I will stop there. But if you have any questions, happy to hear them. I know we're short on time, so I also encourage you to reach out to the email address on the page if you want to learn more or connect about the coalition following the meeting. But thank you all again for organizing this. This has been awesome and really appreciate the opportunity to present.
Thank you, Teresa, so much and for providing us with all these resources. Dr. Eleftheriou, would you like to
I would like first to thank the presenters. They have done a very, very important and significant job in describing protocols and standards of care, both in the adult and in the pediatric population. I would like to thank the coalition for giving us the opportunity to see very comprehensively how they work, and this is very important because it complements the work, because what we would like to see is not duplication of work, but work that complements each other to support these patients. And of course, our own collaborators, Dr. George Galtounis, and very importantly, Dr. Anya Dumian, who have developed our educational programs, and we look forward to their being used by both the healthcare professionals and the patients. So collaboration and networking is very important in moving forward, is very important in providing services for patients with sickle cell disease across the world in the same way as we do for our thalassemia patients. We felt the years before that advocating for thalassemia in the various parts of work, in the various parts of the world, where sickle cell disease patients happen to be members of the same organization, we were simply violating the rights of the patients with sickle cell disease. We felt that we were distinguishing or separating among the rights of patients. Therefore, collaboration and networking is very important, as well as understanding the work of each of the partners, because we would like to benefit from the work of each other. Duplication is not something that we would like to encourage. And therefore, that's why we need to understand the work of each partner so that we can contribute, we can build on, we can support the work of others where some projects are started or some work is being done. Therefore, we feel at TIFF, and we need to stress this, that we are working only on the educational program for sickle cell disease. We are including educational activities for sickle cell disease in every program of Thalassemia International Federation's work and events. And we are seeking support from other partners, as well as to allow us and give us the opportunity to better understand their work. So that's the word for me, upon also thanking each and every one. And this is an interactive session for any questions that can be answered by the distinguished presenters. Therefore, any questions do we have on the chat? It's okay. We don't have any questions. Well, okay, I think that although we have a number of participants, no questions have come up.
Andrula, this is Michele Franceschi. I received a direct question from. Do you want me to share?
Yes, please. Yes, please.
Okay.
Yes, please.
So, she's not or he's not signing, but she is asking, or he asking, whether a patient with sickle cell disease on hydroxyurea can be brought on blood transfusion. And the answer is yes, because sometimes the severity of the disease require both treatment, and the clinician can decide whether blood transfusion should be keep it just for a very short period of time of chronically. And this generally is happening when clinical presentation, as I mentioned, is severe, whether there is a kidney involvement or lung involvement or brain involvement.
Oh, thank you. Maybe Dr. Have you received any other question? If not, maybe Dr. Rinaldi has received any question. In the meantime, if we don't get any question, I need to inform those participants that are here with us and thank them for being with us. In the international conference, we will have a whole session for sickle cell disease, and one of the topics will be a comparison or an analysis or an identification of the guidelines for sickle cell disease. We have done that for thalassemia some years ago with the title Guidelines Talking Between Them. So we would like to have an understanding of how many guidelines are at the national, but most importantly at the regional and international level, so that we can see the differences, so that you can see, the experts, not us, but to help the patients understand the slight or major differences between guidelines as well, because that's important when we're talking about global population. And there is another question for both of you. When would red cell exchange be appropriate versus simple blood transfusion, in your opinion? I think you can both give your responses. Dr. Francesca?
So the question is very interesting, and the answer is complex because red cell exchange that can be administered either as manual exchange or automatized exchange. Not all the centers are able to carry it out. So it needs some, if it's manual, it needs some very simple training before performing. So a part is related to the ability or to the skills of the centers. Concerning the indication, the clinical indication in adults, the red cell exchange is generally used either to control severe acute manifestations such as acute chest syndrome or kidney events involving kidney. Concerning the chronic use, this again is related to the severity of chronic sickle cell complication. Again, we found either kidney failure or liver failure, heart dysfunction. So I think this may generally be considered as main indication for red cell exchange. And of course, this is there was a very nice paper from John Porton comparing the iron overload in sickle cell patient according to the strategy, and of course the exchange is definitely better than a chronic red cell transfusion, since you just remove patient red cells and you infuse donor red cells, so you don't have, or you just prevent iron overload. So the strategy of the red cell exchange versus simple transfusion should take into account also this aspect concerning iron overload.
Dr. Rinaldi has, we were belated on the program, of course, and we do apologize, but Dr. Rinaldi had to go, and any questions, of course, addressed. She's always available too. So Tiff will accept any questions afterwards as well by email, and I'm sure Dr. Francesca and Dr. Rinaldi would be answering with no problem. So, Dr. Michael, any final conclusions?
No, not from me. I just would like to thank everybody, because it's been an excellent summary of the whole issue of sickle cell disease, especially of the educational aspects. Thank you very much.
Thank you very much. Our next steps is that we will review what we've said today and how we can work with our patient organizations across the world in order to convey the message that, educational material is there. We've got activities to do. We've got collaborations to establish. We've got networks to develop, and we're going to make a strategy on that. And thank you very much, Coalition, again, for being with us. Very important. Networking is the most important, and exchange of best practices knowledge. So thank you, everyone. And Tiff is very grateful to all of you. And Gadia, many thanks for such a wonderful moderation and coordination of the whole event. Thank you very much.
Thank you.
Thank you, everyone.
Thank you.
For your time.
Bye.
Bye-bye.
Bye.
Bye.